हेल्थ इंश्योरेंस नहीं इंश्योरेंस प्लान कर रहा है आपसे चॉइस करने को
Sir, you can start the session. Room is open for the attendance.
Yeah, three more minutes.
Okay, sir.
Okay. Okay, we'll start. Good evening to all of you. Today I'll be presenting multiple short cases and one relatively long case. So I'll start with my presentation now. Can you see my slide now?
Oh, yes, sir.
Yes, sir. Yeah, okay. So we'll start with one short case first. This is a story of a 70-year-old diabetic. He presented with the history of shivering of the face and neck since on the day of admission. He was previously admitted here 2 months back in this hospital with left hemiparesis and from which he improved almost totally. This is the complaint he was telling about in the face and neck. Have a close watch on the patient. I'll show it 1 second. Yeah. Look at the face and neck. He said spontaneously subsides after some time. Today morning on examination. So what is the diagnosis in this patient? No other complaint, no headache, nothing. Today morning onwards he's noticed this complaint. Any thoughts?
What's his blood sugar?
I'll show the blood sugar now. 214.
Is that tremor more on standing and less on lying down?
Not like that. It is present all the time, sitting and standing and lying. All the time it is present. Comes episodically and goes off.
Focalization.
Okay, focalization. So what will you like to do in this patient?
Absolute
Okay.
MRI.
MRI, okay. Right. So I'll show you another case. This elderly gentleman was admitted with extreme tiredness and vomiting for the last 2 weeks. He was noticed to have this abnormal movement. Look at his face. Look at the face again. He's talking, answering the questions correctly. You want to see the video once again? I will show that.
Again, the RFT in the other patient.
Pardon?
RFT in the left ear normal.
The first patient, normal. This patient you're talking about? Or the previous patient?
First one, sir.
Most
So-
likely due to hyperglycemia.
Okay, right. Now as regards the first case he was given 4 pints of normal saline. Next day, involuntary movements totally subsided. So what all is said is correct. He has got hyperosmolar state. The point I would like to make is that the blood sugar need not be very high at all. It is not the high blood sugar which causes this problem. Blood sugar may be relatively in the normal range, but it's hyperosmolar state which causes such movement. And various types of movement can occur in hyperosmolar state. Now, as regards the second case, this one, I'll show the next part of the video in this case. This is the second part of the same patient. Now, what is the diagnosis now? But a severe negative myoclonus or asterixis. Sometimes it can involve the body, the patient can make the patient sunk down to the ground. This patient had CKD. Crested asterixis and negative myoclonus, and he had CKD with acute exacerbation. All involuntary movements subsided on the next day with hemodialysis. So just to show you some cases of metabolic encephalopathy which can present with this kind of a movement. So always make sure that rule out diabetes or need not necessarily be high blood sugar, maybe only erythropoiesis state. They can even put this called facial asterixis, which may be confused with automatisms or complex partialization. Now, I'll go to another case.
Facial asterixis, how will it look like?
In fact, I do not know whether we can call facial asterixis, but there is a term given for that. It's only myoclonic movements, jerking movements occurring in the facial muscle, sometimes in the neck. In CKD, you can have both positive as well as negative myoclonus and maybe multifocal. The term they use is facial asterixis, whether I do not know whether you can really call it or not. But these movements are called facial asterixis.
The second case can be called facial asterixis.
Yeah, I can call it facial asterixis. That term is from literature, not my term. That's why I use that term. This 65-year-old diabetic lady was admitted 1 week back with right MCA stroke with left hemiparesis, from which patient was improving. However, for the last 3 days, she gets episodes of decreased responsiveness, apathy lasting for 5 to 8 minutes. During these episodes, patient had to be repeatedly coaxed to get an answer. She's not totally unconscious. Everything becomes slow and follow any commands. Look at the video. This is during the time of the episode.
Okay. Baltekai book. Yadatekai book at some
As left up is left up.
Madeteka Yeda. In the noke. I bet you.
Sorry, I will show that once again. Yeah.
Dr. Vichola, I'm going to noke. In the noke. Ama. When you parna cake. I'm at Yadateka Yeda.
I'm asking to lift up the left. Show the left upper lip.
Edate Verlebra Dotaganiki.
Show the left finger.
Talavar Dotaganic. Talavar Lindi. Talavar Dotaganic.
Thumb.
Matalavar Dotaganic. Ah, say
She's already got the thumb. She's keeping his hand like that.
Not a pig in the Kana.
Has to make her walk.
Like Seri, Madi, Ama Tirchua, Ama, Tirchuane, Ama did name, Ama did Kema.
No, it has become more now. It's become all right.
Then no Kikema, Pero Arnini. Ah, every day. Vertical. Is that an ichine? More. In your day book, at the moke at the time.
It's been totally normal now. Previously, she has to be coaxed many times to get an answer to an activity. So, what do you think the patient might have been having? This occurs again after a few sometimes.
CPS.
Yeah, CPS, right.
Okay.
So, seizure phenomena, yes. But it's already on 3 heptane and frisium 101.
Sugar level, sir.
Right. Sugar was 245.
Maybe hyperosmolar states are fluctuating hyperosmolar.
Exactly. This patient also improved with 4 points of normal saline. They need not give any anticonvulsant. Stop, nothing. Only give saline. 2 days, he'll be all right. Again, diabetic. So this is the various types of presentation the patient can have. So the point is that RBS need not be very high to produce recurrent seizures. Now let us see another case. This elderly diabetic man.
What is the semiology? How will you that abnormality? What is it? It's just an encephalopathy, transient encephalopathy, or it's an electrical event?
It is something in between a seizure and encephalopathy. Some of the seizures need not necessarily be a total loss of consciousness. They can have only a subdued or they may not behave in the customary speed and clarity or subdued activity. She is not totally unconscious. She has to be coaxed many times to get into the play. And look at the hand. She keeps her hand flexed like that. Repeatedly ask her to point out the thumb, she'll point it out. But after this episode, she became perfectly normal. It's some kind of a seizure itself. It's a partial seizure. But the etiology is like this. So what the point is that hyperosmolar state, the seizure phenomena can manifest in various types. I'll show some more phenomena also later on. Now, this diabetic man is having repeated jerky involuntary movements left upper limb and lower limb for 3 days. But this movement does not occur spontaneously. Whenever he attempts to move the limb, it jerks. But otherwise, he's not jerking at all. Look at the patient's when he's lying down in the coat. He's old video. Lift upper limb, then the jerky. See some kind of tonic jerky movement is happening in the left upper limb.
എന്റെ വിരലിൽ തൊടാൻ നോക്കിക്കേ, എന്റെ വിരലിൽ ഇടത് കൊണ്ട് തൊടാൻ നോക്കിക്കേ,
Touch the finger of the doctor. They get the jerky movement repeatedly.
അതിന് ചുമ താത്ത് വെച്ച് തൊടണ്ട, ചുമ താത്ത് വെച്ച് വയറ്റത്ത് വെച്ച് എടുത്ത് വെച്ച് വയറ്റത്ത് വെച്ച്.
No, he has to relax. No, the jerky
but
movement.
occasionally occurs.
There's no jerky movement when he's totally relaxed.
അതിന്റെ വിരലിൽ തൊടാൻ നോക്കി.
Again, asked to lift up the upper limb, he gets the touch the finger jerky movements are appearing.
It is serious.
Proprioceptive seizure.
Action myoclonus.
Okay, proprioceptive myoclonus. Okay, right. Nobody cannot say what you said is correct. It could be a proprioceptive myoclonus. Or can I, if I use the term
No,
intensive
proprioceptive
myoclonus?
seizure.
അതിന് കൈ അനക്കാൻ നോക്കിക്കേ, വയറ്റത്തോട്ട് വെച്ച്
Right.
വയറ്റത്തോട്ട് വെച്ച്
Again, keeping quiet.
കൈ പൊക്കാൻ നോക്കിക്കേ.
Arch lift up, get that thing. No, whether to call it proprioceptive myoclonus or intention myoclonus, we do not. Right. This patient also has, pardon?
Action myoclonus. Proprioceptive seizure.
Yeah. It is a seizure phenomena. Only thing is that it is precipitated by an action. Whether just like kinesiogenic movement disorder is action precipitating the seizure episode, or as if somebody said, proprioceptive input causing seizure episode, we do not know. But whatever it is that he had diabetes 450 and everything subsided in 2 days' time with just normal saline. So this I'm showing the various type of presentation of hyperosmolar state. This is very important because it's eminently treatable condition, very, very eminently treatable condition. I'll show another case, again 64-year-old diabetic right-handed man, present with episodes of visual disturbance in the form of difficulty in seeing on the right side of the visual field, associated with flashes of light. The episodes used to last for less than an hour, no altered sensorium, nothing. This repeated itself many times for the last 6 hours prior to admission. Examination showed right homonymous myopia with mild right-sided weakness. What is your diagnosis?
Hyperglycemic.
Yeah, why can be TAA?
PC.
It could be TA also, no?
Could be TAA.
But the clue was that he has got that positive phenomena is there. That does not mean that TA cannot produce that like that. When a diabetic, anything any focal deficit occurring repeatedly like that, whatever be the phenomenology, consider hyperosmolar state. This so brain normal, angiogram normal, and blood sugar is 450. No further episodes after starting 4% normal saline produced. This is literature. No? This is one article. Hyperglycemic hemianopia, a reversible complication of non-ketotic hyperglycemia. So this sometimes negative phenomena alone can be the manifestation of focal seizures in hyperosmolar state. They can present paroxysmal blindness and paroxysmal behavioral disturbance, just like that shown before. I'll show another story of a 60-year-old woman. This is a little different. This diabetic lady was admitted in the ICU with altered sensorium. The ICU people noticed some involuntary jerking movements of the abdomen. We were called to see the patient to give an opinion regarding the abdominal jerkiness. This was the jerky movement. Just one clear time. Okay.
ഞാൻ കൈയൊന്ന് മുമ്പോട്ട് വെച്ചേക്കാം. ഇവിടെ സപ്പോർട്ട് കൊടുത്താൽ മതി. എന്നുവെച്ചാൽ എനിക്ക് രണ്ടും കാണാൻ വേണ്ടിയിട്ടായി.
So what do you think the patient is having?
Diaphragmatic myoclonus, dancing belly syndrome.
It's like a dancing belly.
So diaphragmatic myoclonus.
The honest part, I can agree with that.
ഞാൻ കൈയൊന്ന് മുമ്പോട്ട് വെച്ചേക്കാം.
It is rhythmic movement, no? Rhythmic movement.
ഇവിടെ സപ്പോർട്ട് കൊടുത്താൽ മതി. എന്നുവെച്ചാൽ എനിക്ക് രണ്ടും കാണാൻ വേണ്ടിയിട്ടായി.
What do you think the patient? What could be the cause?
Hyperosmolar state can cause diaphragmatic myoclonus.
Exactly. And look at the hand fingers, even it's also moving synchronously with the fingers. Now, the second part of the video will make more obvious. After some time, she started developing jerky movements of the lower limb as well.
It's like epilepsy partialis continua of the diaphragmatic muscles.
Yes. Just
ഒരു ലോവർ സ്റ്റെപ്പ് എടുക്കേ.
Parts continuous due to hyperosmosis. This also had a hyperosmolar state. Okay. Now, another case of almost similar abdominal wall myoclonus is 65-year-old lady. Now, what do you think this is? She had a brainstem stroke 4 months back and recovered. What do you think about that thing?
So dancing belly syndrome, sir.
Dancing belly. No, I'll come
Yes,
to
sir.
that. Now, what is the semiology? Is it myoclonus? Is it something else? What do you call?
So
Also,
shudder
the-
type is not clear.
Now, can you see that?
Segmental myoclonus.
No, this is not, you see, it is rhythmic, no? It is a rhythmic tremor-like movement, the diaphragmatic tremor, okay, or a flutter-like movement. In fact, where do you get rhythmic flutter-like movement in following a brainstem stroke?
Central tegmental tract syndrome.
Right, exactly.
Muller triangle.
So the central tegmental tract lesions can produce ocular myoclonus, can produce palatal myoclonus, laryngeal myoclonus, as well as diaphragmatic myoclonus and axial myoclonus. So those structure developed from the branchial arches can develop this going to this jerky movement. So she had a brainstem stroke early. She also had palatal myoclonus, and this is a diaphragmatic flutter. We call it diaphragmatic flutter or diaphragmatic tremor. We can call that, no problem, because the movements are all rhythmically coming. It's got high frequency involuntary contract diaphragmatic muscles. It is often accompanied by contractions of the respiratory muscles. There are many causes for that, need not necessarily be due to a brainstem stroke. It has been described in many conditions, irritation, pleural disorders. These are all causes that can cause diaphragmatic myoclonus. Following osmotic dysfunction. Basically, essentially, it's a dysfunction of that central Muller triangle. Muller triangle. Now, another abdominal problem I'll show. What is this one?
2 years. Also, he has abnormal posturing of the
It is entirely different from the previous one. Okay, what do you think about this?
also
Paradoxical respiration.
No. It is not intermediate. Look at the muscle. Going upward and contract, going to one side. See? The upper part is going upward. The umbilicus is pulled up like that. Remain for a few seconds and comes back again. Semiologically, what do you call that thing? A
Is it
movement.
belly dancer dystonia?
Yes, yes. It's a something like a dystonic contraction. See, if you look very carefully, it goes up and remains for a few seconds, then comes
Also,
back
he has
again.
abnormal posturing of the.
See that one? It is not rhythmic at all. Okay, and comes back again. That is belly dancer dyskinesia. Most of the times it's idiopathic. I do not know why it's what causes that thing. We investigate, we do not find anything in these patients. Diaphragmatic fracture could be distinguished from belly dancer dyskinesia. The reason is that the point is that diaphragmatic fracture causes semi-rhythmic checking of the abdominal wall and displacement of the wall by the diaphragmatic activity. In belly dancer dyskinesia, abdominal movements are writhing and contorting, just like which I have seen, slowly displacing the umbilicus by the contraction of the recti and oblique muscles. You can see that particular last point. You can see this in this video once again.
2 years.
See that one? It is
Also, he has abnormal
writhing and
posturing of
remaining
the.
for some time and pulling the umbilicus to one direction, keeping for some time. Okay. I will show one more involuntary movement. This man was in a locked-in state. It's actually Joy's case. For the last 2 years, following basilar artery, no, not 2 years, now it's 10 years now, following basilar artery dissection. This is the movement in the lips. What is it movement?
Perioral myokymia, sir.
Myoclonus is something like undulating movement. See the movement. I will show once again. Look at the movement. Look at the rhythmic movement, rhythmic contractions of the facial muscles. The rhythmic movements are like a tremor-like movement. So what is this one? Again, a facial tremor. This is also a lesion due to Glenn-Muller triangle. In fact, he had a basilar artery dissection producing a pontine infarct, and this movement developed subsequently. And opening the mouth, he has got a palatal myoclonus. Palatal. Some people, it's not actually palatal myoclonus; it should be palatal tremor only, because the movements are rhythmic. Sometimes it can be confined to the facial muscles also. It may be even one side when one of the inferior nucleus or superior epidendrum on the contractile side is happening on one side, the movements can be confined to one part of the face. Similarly, the palatal myoclonus can also be affected only one part of the one half of the palate, depending upon where the site of lesion is. It's only mainly on the left side. If you look very carefully, the upper part of the face also blinks. Okay, any questions?
So, sir, phenomenology wise, that should be tremor, no, sir?
Rhythmic movement, tremor-like movement, tremor, yeah. Or you can call it rhythmic myoclonus. That's also possible. One of the rhythmic myoclonus is seizure itself. When you get repeated rhythmic myoclonus, it is just like a seizure phenomenon. But here is a tremor, nothing due to brainstem lesion.
And does that respond to the usual treatment, sir?
No, very difficult to treat. They do not usually respond to any targeted treatment. The second due to Glenn-Muller triangle. There is another type of palatal tremor called idiopathic palatal tremor. They usually can, most of them are functional, but they in organic conditions they can respond to treatment like gabapentin, paclopen. They can respond. Now, this is a very interesting movement which you may not have seen before. I have seen only for the only once I have seen. When you blow the air on the face, you get a jerky movement of the face. You look at the face jerks and the neck. What I'm fanning with the paper. When the air falls onto the face, you get this movement.
Aerophobia, rabies.
No, it's not aerophobia because he has no aerophobia, no hydrophobia, nothing.
Stimulus sensitive myoclonus.
Sensitive myoclonus.
Okay. This is one thing is stimulus sensitive, responding to the airflow, and the way the air is, air is blown onto the face. And it is, if you look very carefully, it is only the face jerks, face muscle jerks, and the neck on the right side. Look at the facial movement. On the right side of the face is jerking. See that? And there is a clue. Look at the things what has happened on the face. He had an injury on the face. That's on the cheek, there is an injury, and subsequently later on you develop this kind of a stimulus sensitive jerky movements of the face.
Tetanus.
Yes, perfectly right. This is called very rare condition called cephalic tetanus. This is called cephalic. They do not may not produce trismus and all. They may be confined only to one or two muscle groups producing this kind of a stimulus sensitive spasms or jerky movements. This is an old case of this from literature. Cephalic, he had an injury on the face. On the left side, he has got this kind of a facial palsy and episode of jerky movement. And usually following trauma injury to the face, then the toxin will, go into the facial nucleus, and then they get produce this kind of a jerky movement, stimulus sensitive. Okay, so that finishes the.
Sir.
Yeah, please.
Boy.
Pardon?
What's the prognosis? What has happened to him?
This patient improved. These cephalic tetanus patients usually they improve. Generalized, even generalized drugs also can improve, provided depending upon the care of the patient. He improved very well. Treated in terms of this anti-tetanus toxin, this thing, anti-tetanus one, plus other benzodiazepine and things like that. Basically, it's hyperactivity, disinhibition of the anti-T cells. Or anti-T cells, so in the case, strengthening nucleus. Okay, shall I go to the next case?
Yes.
Or any questions? Okay. This 34-year-old female today in involuntary movement session had presented with episodes of abnormal posturing of both hands, inability to open the jaw, difficulty in articulation, and inability to open her eyes for the last 3 years. So episodes of abnormal posturing, I'll show the abnormal posturing, inability to open the jaw, difficulty in articulation, inability to open her eyes for the last 3 years. The episode used to last for 10 to 15 minutes and may recur 2 to 3 times on certain days. Erratic. And this is one such episode when I saw in the casualty. She's unable to open her fingers like this. Unable to lift up her hands. Look at her face. She's got the face becomes contorted, unable to open the jaw. Difficult to open the jaw. She's unable to open her hands. I make her open again, comes back like that. So, what do you think the patient had this for 3 years?
That is
Pardon?
status dystonicus or dystonic storm.
Yeah, this is a dystonia. Perfectly right. But it's affecting not only limbs.
It is paroxysmal non-kinogenic dystonia.
Okay. But does it affect? Yeah.
What was the calcium?
Calcium level.
Yeah.
Plus tetany will come.
This is the second day after treatment. What you guessed is correct. She has got underwent thyroidectomy 4 years back, and serum calcium was 4 milligram. So sometimes hypocalcemia need not produce so-called typical carpopedal spasms around may not be there. Sometimes the spasm may be in the form of clenched feet. Even they can present the trismus mimicking a tetanus. So any dystonic contraction of paroxysmal nature, try to rule out hypocalcemia. That is a lesson I want to tell, whatever be, because it's a very simple thing to diagnose, simple to diagnose. Only serum calcium is required. We need not any genetic test and things like that. So always consider this possibility in the back of the mind. Any kind of paroxysmal involuntary movement, you keep this hypocalcemia in the back of the mind. Not only with so-called carpopedal spasm, you can put dystonic spasms of in various parts of the body, even trismus mimicking tetanus. Okay. So that finishes the involuntary movement section. Any questions? Okay, shall we go to the next case?
Yes.
Yes, sir.
This patient, I don't have a video, only the photograph is there. It's a interesting problem. 40-year-old man, his sudden onset of headache and vomiting. Associated with that, he developed blurring of vision, which improved with closure of either eye. So most likely it's a diplopia. He also had tinnitus of the right ear and numbness of the right half of the face. I'll show you one side. This is sudden onset of headache and vomiting with most likely diplopia, but he complained of blurring of vision, tinnitus of the right ear, and numbness of the right half of the face. Okay. This is the head posture he is having. Okay, he'll tilt to the left side. The extraocular movements reveal right superior oblique paralysis. That is why his head is tilted to the opposite side. And then he has got the findings on examining head tilt to the left side, right superior oblique palsy, decreased pain on the right half of the face. But the corneal reflex was normal on both sides. He had mild gait ataxia. No neck stiffness, but Kernick sign was slightly positive. So this is the finding. So where do you want to localize? You can take some time to think about and then let me know the answer. Any clarification in the history and findings you can ask.
Left lower midbrain.
Okay, left lower midbrain. Okay. Any other thoughts? Okay, let us see. What is the okay. Let us see, just for discussion's sake. Is the least extra? The first thing is extraaxial to intraaxial. Let us consider extraaxial lesion first. In the apex of the petrous temporal bone, why can't be lesion there? We can explain the right fifth nerve. The numbness can be there. Right superior oblique weakness as well as tinnitus on the right side with extension to the right CP angle. Why can't be lesion there?
Corneal reflexes.
Okay. Corneal reflex is not normal. Is normal. That's a point. But all this need not necessarily a corneal reflex lost.
Superior oblique palsy.
Yeah, you've got a superior. That's a right fourth nerve is affected. Right fourth and fifth all in the posterior part of the cavernous sinus.
Gait ataxia, sir.
Okay, but gait ataxia. That is a point again. But maybe the lesion is compressing the brainstem. Gait ataxia very mild. Okay, let us see. So let us see if x-axis how to explain the ataxia. That's already pointed out. And why is that corneal reflex is normal in the right with sensation effect on the right face? The point you already narrated. So that's a little odd against extra-axial. Then if it's interaxial, where is the lesion? Is it on the right side or left side?
Left side.
Okay, why left side?
Superior oblique nucleus on the left side.
The superior oblique is on the right side.
Affected.
Everything can be explained only by left side lesion.
Opposite side.
Exactly. So but initially may think the right pontine lesion because everything is on the right side. Right ataxia right side, fifth and sensory loss on the right side, seventh on tinnitus on the right side. So this can explain the fifth nerve ataxia and right seventh nerve possible extent of the cochlear nucleus adjustment tinnitus. So what is all? How to explain the right fourth nerve palsy? Because it's a brainstem lesion means the fourth nerve is on the contralateral side. So if it's a right pontine lesion, you expect a fourth nerve to be on the left side. Here it is on the right side. So that is unlikely. Now, then what any other possible side? Is it left-sided lesion? Left, where it should be the lesion on the left side.
The corneal reflex was preserved. That may involve the quintothalamic tract on the left side.
Very good. Perfect. Then left superior oblique palsy can be, sorry, right superior oblique palsy can explain the left-sided lesion. Then
Tinnitus by the
Tinnitus on the right side.
it is on the right side.
that's the left left the cochlear thing on the left side.
Left cochlear lesion.
No, not the left cochlear lesion. That thing which extends, process and goes to the left side.
What do you call that thing?
What's that called?
Cochlea is much below. Cochlea is much below.
Not cochlea, the other one. Forgot the name.
Okay, I know what you have in mind, Joey. I'll tell it later. Okay. Okay, what do you want now?
MRI.
At that time, this is an old one. MRI work could not be done. He took a CT scan. This is a CT scan. MRI points normal. And this is the MRI of the midbrain. So what did you observe on the midbrain? Enlarged
Some
view.
bleed somewhere.
Right. So it's on the right side or left side? It is on the left side. Okay. It's affecting as you say correctly, lower part of the brain, midbrain, in the tectal region. The region of the fourth nerve, superior oblique nerve.
Tectum. Tectal deafness.
This is called tectal deafness. This is MRI. Then subsequently showed the lesion on the left side. Again, you can very clearly make out the hyperdensity in the left tectal region.
You had the video of this patient. You have shown this before.
Yeah, I have shown some time back.
No, video also you have shown. Only the photos.
No, video was not there. This way, I could never get the video. This is an old patient. When I was in Kottayam Medical, I saw the patient. He was an old patient. That day, there was no video technique, was not there. Only photo. Now, how to explain the pain loss on the right side of the face? It can be to the effects of the spinal nucleus tract on the same side or ascending quintothalamic tract on the opposite side. So here, it is most likely due to, on the left side, as you all said, because the corneal reflex is preserved. If it is the descending nucleus tract is affected, you would expect the corneal reflex to be decreased. Whereas once it crossed, it becomes, the corneal reflex will be preserved. This is how the fibers are descending down into the spinal nucleus. There's a descending tract, then cross ascend up to the in the ascending endothalamic tract. So if there is a lesion here, on the left side of numbness can be due to lesion here or here. Lesion in the descending nucleus will affect the corneal reflex, whereas other on the other side will not. The same point already said. No, what is it? Why there is a tinnitus on the right side? It's a tactile deafness. Deafness, because you can have tactile deafness. Tactile region can also produce deafness due to lesion inferior colliculi. Here, pure tones are spared, mimicking pure word deafness. And this is from the literature. The symptom, I think I'll skip this thing. This is a site of lesion, which are pictorially represented here. This is the inferior colliculus. The green one is inferior colliculus, and this is the spinothalamic tract. The anterior part will be the anterior part will be the spinothalamic tract. The posterior one will be the quintothalamic tract. See, even though they are separate in the medulla, a little outward, as it ascends towards the midbrain, it becomes a single tract. Where the face fibers come to posteriorly, the upper limb these fibers comes medially. See, this is the nerve is affected on the left side. That is both the nucleus, so the nerve is affected. Then the location ascending quintothalamic tract that will produce loss of pain and sensation in the contralateral face. There is a tectomy is affected to account for the deafness. So that is a lesion which we have seen in our patient. Explain everything on this patient. So the first thing we tend to think of a right-sided lesion, but actually lesion was in the left side. Okay, any clarifications or questions?
So was there any nystagmus in this patient?
No nystagmus. No nystagmus. Because that area need not produce nystagmus because there's no vestibular connection is not coming there.
The auditory fibers cross at that level, sir.
Pardon?
The auditory fibers crosses at what level? Same level as
No. In fact, already see these fibers crosses at various levels. No, they're ascending in the trapezoid body, then ascend ipsilaterally and contralaterally. But main contribution goes to the contralateral nucleus. So it's got bilateral goes to the one-sided here and afferent from the ear goes to both tactile inferior colliculus. But the contralateral, the fibers go predominantly to the contralateral inferior colliculus. That is why you can have a contralateral deafness or contralateral tinnitus.
the crossing is at the pons itself.
No, at the pons itself, the pontomedullary junction itself. They cross and ascend. On the way, it ends in the superior olivary nucleus, which produces a feedback. The retrograde impulses go to the auditory nucleus to suppress the auditory input. And the crossing in between is called the trapezoid body. This picture clearly shows this TL is the trigeminal lemniscus that is ascending quintothalamic tract. Here is the spinothalamic tract. This is the the fourth nerve. And this is the thing. Suppose a lesion is there here in the crossing, superior medullary velum. You can have bilateral superior oblique pulsing. If the lesion is the posterior part of the midbrain, you won't have any long tract signs. That's another peculiarity is that if you get lesion confined to the nucleus or crossing fibers, no longer, because all long tracts are anterior. Long tract by which mean pyramidal, cerebellar, and everything will be preserved. That is why there is no nystagmus also. Okay. Any questions?
So in such situation, how do we localize to the extraaxial one?
The point in the first thing we naturally think is extraaxial, no? But actually, because we can't explain everything by extraaxial. Because the main point is the superior oblique can't happen to be on the opposite side.
No, if it is bilateral, lateral superior oblique.
Superior oblique, it can occur with bilateral cover sense, which can definitely produce. But usually in such situation, we'll have accompanying other canelas will be affected. 3, 4, 6, and it goes with 5, 1 or 5, 2 are all going along with that. But only bilateral fourth nerve alone is affected. without involvement with other cranial nerves. Think of a dorsal midbrain lesion, the superior medullary velum. That is where it crosses. A lesion compressing at that level can produce bilateral superior palpitations. And the lesion here, see on the same way which I shown, you can have even a contralateral RAPD also. Lesion goes little proximal and upward, it can cut off the pupillary light reflex pathways bending in the superior preauricular nucleus and go into the third nerve. So you can have contralateral RAPD. The other, if you are asked on exam question is that somebody has got normal vision with RAPD, lesion has to be in the tectum.
Tectal RAPD.
Tectal RAPD, but the vision will be normal. Because the visual pathway goes enters the genital body and goes through the cortex. But only the light reflex pathway come to the midbrain. When that is affected, it is equivalent to an optic tract lesion. Optic tract lesion on the left side produces a right-sided RAPD. Because the temporal field is represented, that means nasal retina is more. So you get a right-sided RAPD is there.
So in that case, should we also get lightning and dissociation phenomena with the RAPD? Because
in that location, lightning dissociation will be there. It will be there, definitely. Because lesion is in the pretectal region or tectal region.
ഒന്നുകൂടി പറയാമോ സാറ്?
അതായത് the explanation for you want explanation for the RAPD or explanation for the lightning dissociation? Both, okay. First I will tell you about the RAPD. RAPD classically indicates a lesion of the optic nerve, as you all know, because the afferent is affected. Relatively, that afferent input from one eye is affected compared to the other eye. That is the basis of RAPD. So even if you got a bilateral blindness, if there is significant asymmetry is there, you can have RAPD. What we are checking is the relative difference in the input, relative difference between the right and left. So that is why RAPD usually indicates an optic nerve lesion, but invariably indicates. Sometimes RAPD can occur in optic tract lesion. If you take an optic tract, it contains ipsilateral temporal fibers and contralateral nasal fibers. Correct?
Yes, sir.
Okay, so you won't get RAPD because that from the light reflex light can pass through the other pathway. So you won't get RAPD generally in optic tract lesion. But sometimes you can have RAPD on the opposite side because if you take a left optic tract, it contains more of nasal fibers, less of temporal fibers. Why more of nasal fibers? Because nasal retina is more than the temporal retina. Why nasal retina is more than temporal retina? Because the temporal field is always more than the nasal field. So nasal retina is responsible for viewing the temporal side. As you know, if you look at the field charting, temporal field is more, 110. Nasal part is only 50. So the nasal retina has got more of fibers coming inside or more of ganglion cells. So they pass the visual information into the brain. So if you take a left-sided optic tract, that contains left temporal retinal fibers and right nasal retinal fibers corresponding to the field. So what will happen? It is essentially because the right-sided eye is more blind compared to the left, even though it's only one field, because that retina is more affected than the left. Okay. Because the other side, the nasal retina is more affected on one side. That will be more, that's contralateral. So you can RAPD on the right side. Have I made it clear to you? Okay. Now imagine that just optic. So if you get an optic tract lesion, you can have a contralateral RAPD. More not only that, you have got a contralateral field deficit also. Right, because the visual pathway is there. What happened to the visual fibers? It remains in the genital and go to the optic radiation of the cortex. Some of the fibers which does not, this papillary light reflex pathway does not enter the lateral geniculate body, then goes posteriorly through the kind of connection between that and the superior colliculus, the brachium of the superior colliculus. So if that is affected, only the light reflex pathways are affected. So what will happen? The vision is not affected. At the same time, the pupillary fibers coming from the contralateral nasal retina is affected. Just like optic tract, you get a contralateral arrangement. Because the extension of the optic tract, the pupillary fibers in the optic tract is coming to the midbrain, dorsal midbrain. Is it clear now?
Yes, sir.
Yeah, okay. So that's regarding the RAPD. So in the exam, somebody asks you RAPD with a normal vision, think of tactile RAPD. Now coming to the next one, what is the mechanism of light and dissociation? This is the light reflex pathway coming to the lateral body, coming to the pretectum and going to the edingular nucleus. The accommodation pathway are two pathways. One is through the Virgin system, the proprioceptive input from the, when you converge the eye, the proprioceptive input coming from the medial rectus go posterior through the nerves go posteriorly into the mesencephalic nucleus, that is proprioceptive nucleus of all the cranial nuclei, cranial nerve input. From there, it directly goes to the edingular nucleus. It does not go to the region of pretectum at all. That is one accommodation pathway. The other is the occipital cortex, the visual fibers called occipital cortex, from there to the frontal cortex, then directly come the edingular nucleus. So the accommodation pathway does not involve the pretectal. So it is different from the third nerve involvement, edingular nucleus, because the English will be affected both accommodation and the light reflex. The tectum only affects the light reflex, will spare the accommodation. That is why you get linear dissociation tactile trace. Simply talking, the accommodation pathway does not involve the pretectal trace. Any more questions?
Sir, please, last part, sir, I could not hear because of some technological problems, sir. Last part.
Definitely, I'll repeat once again. In simple terms, the accommodation triad involves the pupillary constriction, the vergence movement, as well as the accommodation, the lens accommodation. Now, there are two ways this can. Suppose there are two pathways for accommodation. Somebody is speaking in bit. Okay. One, the visual input itself can produce accommodation. Suppose, give an example. You close one eye, just close one eye, and you look at the finger in front, far in front, then closely approximate your finger towards your eye. Your eye is not converging, that eye is not converging, but still you see that the pupil is constricting. That is called the accommodative, that is just because for the accommodating purpose is there. Because you have to see the object at a near place, that lens has to become solid. That has to, the sternum will get relaxed and the lens has to become bulged out. The ciliary has to contract. That means the visual, that is by the visual input. So here nothing is there, only visual input is there. No adduction movement is occurring on that time. So that visual input, what will go, has to go to the occipital cortex. From the occipital cortex, go to the frontal cortex. From the frontal cortex, go to the edingular nucleus and produce constriction of pupil, both sides. That is one pathway for the accommodation. The other pathway is that suppose you are blind, totally blind, you cannot see anything. Still, you can have accommodation reflex. This is called psycho-optic reflex. That means, suppose you are totally blind. You show a finger in front, just his own finger, it should be his own finger, and ask him to trace the finger towards the nose. He is not seeing the finger, but the appropriate input is there. He can feel is coming towards the nose. The eyes will attack, the eye will attack and pupil will constrict. Even though he is not seeing the finger, imagining that it's looking at the finger, because the mind is seeing the finger. It's not seeing it, but the proprioceptive input can guide. It knows that it is coming towards your body, nose, and it produces a convergence movement as well as pupillary constriction. So there what is happening? It is the pupillary constriction occurring. There is no visual input, but there the input is coming from the proprioceptive input from the medial rectus, the adducting muscles. So that input go to through the third nerve, it goes to the mesencephalic nucleus of the third nerve. That nucleus is the proprioceptive center for all the cranial nuclei. From the proprioceptive input, it goes directly to the inicular-vestibular nucleus and produce. The rest of the pathway is same. Produce a constriction of the pupil as well as the ciliary muscle dilatation. The lens to become dilated because ciliary muscle constriction. Is it clear to you?
Excellent, sir. Excellent.
Okay. That is why. So in both the situation, it does not come to the tactile region. Whereas light reflex pathway always has to go through the tactile region. Because the pretactile region, it has to come to the pretactile nucleus, then only cross to the opposite side.
Thank you.
Shall I go to the case? Next case?
Yes.
This is one more case is there for today.
Yes,
Other
sir.
is a long case which I will present next week. This is not that short case, it's a good case also. 34-year-old man is to walking difficulty in the form of dragging left foot and loosening the chappals from the left foot for the last 1 year. Clumsiness of the left hand for the last 7 months. Inability to hold heavy objects in the left hand for the last 3 months. So pointing to left-sided weakness. Then another thing is the history of episodes of tinnitus of the right ear, followed by facial deviation to the left side, and uprolling of eyes, and abducting posture of the left upper limb lasting for 2 to 3 minutes for last 1 year. So more like a left focal seizure preceded by an aura in the form of tinnitus. These episodes used to occur 3 to 4 times a month. Last attack was 6 months back. So this is a story of a 30-year-old man. Walking difficulty in the form of dragging on the left foot, then clumsiness of the left hand, unable to hold objects with the left hand, then some like a seizure phenomena, tinnitus right ear, followed by facial deviation to the left, then uprolling of eyes and abducting posture of the left upper. Occurring at 3 to 4 per months. And you can, if he is telling the story, even if it's Malayalam, you can understand. This is how it's occurring.
എത്ര നേരം എങ്ങനെ നീക്കും? അത് ജസ്റ്റ് ചിലപ്പോ 1 minute, ചിലപ്പോ 15 seconds. അതിങ്ങനെ വരാൻ തുടങ്ങിയിട്ട് ഇപ്പൊ എത്ര നാളായി? അത് ഒരു 1 year ആവും.
So you can see this is the type of seizures he's getting. Okay, rest of the examination. He has got nystagmus is beating to the left side. Ocular movement is normal. On looking to the right side also, it's got nystagmus beating to the right. You can see the nystagmus. Rest of the cranial examination normal. He's got mild hoarseness of voice. But palate was normal. Then examines he's got spasticity bilaterally, not only one side. Slightly more on the left side. Power, however, was normal in the upper limb. It's got mild incoordination on the left side. The only part of spasticity is there. Power was normal in the lower limb. Left dorsiflexion was weak. Left AHL was weak. That is weak on the left side. Plantar flexion was normal bilaterally. Abduction, adduction normal. Hip extension was also normal. Both biceps and supinator normally are slightly brisk on the left side compared to the right. Supinator also brisker on the left side compared to the right side. But triceps was sluggish bilaterally, just elicitable, almost absent. Finger brush was also absent. Abdominal flex is present but sluggish present. Both knee jacks were brisk, slightly more brisk on the left side. Ankle jacks are normally elicited. Plantar was going bilaterally. Sensations were all normal. Sorry. Is it correctly? A tremendous difficulty in getting up from bed. And Romberg's was negative. And walks with a wide base and spastic gait. He could get up from sitting position. His power was good, but mildly attacks he couldn't get up. So an examination, high functions normal. Head gaze evoked nystagmus, other clearance were normal. Motor spasticity of both upper and lower limb. But power weakness was only left dorsiflexus in evertus and EHL. Other muscles normal. DTR upper limb biceps supinator normal. Decreased triceps and finger flexion bilaterally. Knee jack brisk bilaterally. Ankle jack normally elicited. Plantar upgoing bilaterally. Sensations normal. Wide-based spastic gait. Romberg's negative. So where is your localization?
Sir, here, sir, is very much clarified. Sir, he has got definitely some upper motor neuron signs.
Very good.
Also, he has got subtle signs for the lower motor neuron. The upper motor neurons are predominantly located in the left side, though he has got the bilateral involvement. And also, he has got some lower motor neuron sites sparing the sensory system. So predominantly motor system we are dealing, where there is a combination of both upper as well as the lower motor, but the predominant upper motor neuron signs.
But what is evidence of lower motor neuron in this patient?
Lower motor, I am just telling in the form of, sir, that is the loss of tricep reflexes and EHL weakness. So,
but EHL we suppose.
Maybe due cortical also.
Yeah, pyramidal lesion is more on the left level. They can also produce, but their point is actually they can be associated LML lesion, but we are not very sure. Can be part of
And
a
also he has got some amount of ataxic gait, which looks like that of a broad-based cerebellar problem.
There no doubt about the cerebellar involvement because he has got nystagmus also.
Yeah, so he has got the Gay-Zyberg nystagmus. So cerebellar involvement, upper motor neuron lesions. So probably some type of a spinocerebellar problem we are dealing, which may be either due to a spinocerebellar ataxia group, or it may be due to an atypical form of a hereditary spastic paraplegia.
But he had one common complaint was left focal seizure.
Oh, he had a seizure, no, sir?
Seizure also is there. Principally aura in the form of tinnitus.
Yes.
We have to include two lesions, sir. One is the cortex in view of the focal seizures. Another may be in the brainstem, sir, because there is hoarseness of voice, ataxia, and bilateral pyramidal signs in a brainstem lesion with cortical lesions, sir.
Perfect. That's the thing. More likely, it's got definitely cortical because of the seizure there, and the other things can be explained by a either cerebral hemisphere cerebellar or a brainstem lesion. Both because only no definite clue for brainstem, but the things which can logically come together is in the brainstem. Only the point was favoring is that hoarseness is there. Otherwise, it will be difficult to say. But that palatal movement is grossly normal. But that hoarseness part, if you take part of 10, definitely it has to be brainstem. Okay, so these are the possible. The one is the flocculus. Why flocculus? He has got a gaze from nystagmus. Then cerebral cortex on the right side near the auditory cortex because for the cords of focal seizure present by tinnitus. And bipyramidal sense spasticity is in the cervical cord or the hemisphere, we do not know. And weakness of the left foot may be part of asymmetrical pyramidal lesion or an unrelated element as you were telling. So you agree with that?
Yes, sir.
Okay. Now let us see. What investigation do you need?
MRI?
MRI. So this is the MRI. Have a close look at the MRI. This is the lowermost cut in the upper cervical cord. Hyperinsular in the center. This is the lower part of the medulla. This is the mid pons and midbrain. Thalamus, midbrain. Basal ganglia. This is the T1 weighted. I'll show the picture once again. Don't worry. T1 weighted. So the hyperintensity is equal by hypointensity. See the size of the medulla. This is the lower medulla and this is upper medulla. This is the pons. This is the diffusion sequence. This is again the hemispheres. And I think this is a flare, not diffusion. Sorry, this is the diffusion. The other thing is a flare. This is the cervical, upper cervical cord and lower brainstem. So, what do you think the patient might be having?
LPSL, adult onset Alexander's, and leukoencephalopathy with brainstem and spinal cord hyperlacticosidosis.
Fantastic. I think you're all well versed with rare diagnosis. Okay. So, what is it is exactly correct. So, what you find here is this is the two. I'll show you once again. It's got severe atrophy of the cord. See, the atrophy cord is atrophied. And I'll show the first video first.
Are there cystic lesions there in the cerebellum?
And there is some hyperdensity there, whether it's maybe it has gone on to encephalomalacia like thing, but there's a atrophy is there and some cystic changes. And look at this is upper medulla. You can see the cystic changes in the peduncle region. Then enter the T1. T1 again shows atrophy. And see the size of the medulla. Medulla is shrunken. And again you see the upper medulla, again shrunken, with some cystic changes in the part of the peduncles. And flare shows that thing. And there is some frontal subcortical hyperintensity in the frontal region. adjoining the frontal area. And this is the diagnostic clue in this picture. What is the diagnostic clue here?
Like a LETM-like picture with cord atrophy, which we find in LBSL, sir.
Oh no, not like one peculiarity is that see the pons is okay. The
Yeah,
medulla is
tadpole.
more what do you call it? Tadpole sign, correct. This is the head of the tadpole and the tail. And the medulla shows marked hyperintensity and the cord is also atrophied.
This is Alexander's or something else?
This is adult onset Alexander's disease. So atrophy of the medulla and upper cord, hyperintensity of the corticospinal fibers, analysis of bright matter and simplicity. So the investigations all were negative. Now the
What's
thing
the
is,
contrast given, sir? Contrast for that garland type of.
that is not given because this was taken long back.
So the medial corticospinal tract involvement can explain the lower limb foot drop.
Yeah, correct. What you said is correct. It can be explained that. That is what I initially, but the only thing is that even to the pyramidal tract lesion, only a foot drop, nothing else. There's no weakness of the hand. That's one odd point. So I'm not least confined only in the distribution of the conperoneal. So always keep the other possibility also in the back of the
The
mind.
neuropathy may be associated with both LBSL and Alexander's.
Correct. That is another point. So did a conduction study, and this is the conduction shows decrease amplitude on the left conperoneal. Others are all normal. So is a part of the nerve or part of the syndrome or is unrelated pressure palsy? We cannot be very sure because only one nerve is affected. Other nerves are all normal, and this is supraperoneal, exactly the distribution of the conperoneal nerve. The only one nerve is affected, all others are spared. That is not the presentation of a metabolic or a neurometabolic neurodegenerative disease, conferring only one nerve. So personally, I think it's unrelated pressure palsy causing that conperoneal palsy. All of the nerves have got a normal conduction. I think these are all done negative. But what we should have done is a genetic test, but which could not be done. But all of the features are fitting with Alexander's disease.
So CSF for lactate was done?
Yeah, CSF was lactate. Let me see. CSF serum lactate. No, that was not done. Why what for? Mitochondrial. What do you have in mind?
Sir, this leukoencephalopathy with brainstem and spinal lactic
LBS.
acidosis.
But I'll tell you one thing. Here, this pattern of involved in the brain is very typical.
Yeah, fits more with Alexander.
Because Alexander is the classical one is frontal subcortical that this patient has. The adult onset other feature is the medulla and the upper cervical cord that this patient has. So that picture is very much like an adult onset Alexander's.
So the cause of seizures in this patient, sir?
That is involvement of the frontal lobe is affected. No,
So usually we see leukodystrophy affects the white matter, sir.
In fact, the many times leukodystrophy can present with seizure. It need not necessarily be that it need not occur. It can present.
So what is about the head size or circumference?
That is normal in this patient. This is one case where you can have a megalencephaly, large scale. The other is connivance, other is megalencephaly leukodystrophy. So I don't think he had a megalencephaly. I don't remember that, but I'll show let me see the picture once again. There is a large skull. It does not have that, to my knowledge. No, it looks normal only.
Sir, only in the garden variety of Alexander's, we might get a megalencephaly before the closure of the sutures. But in adult onset Alexander's, we may get a normal head circumference.
Normal head, perfectly right. Yeah, what you said is correct. When in different onset, it is there. If it is there, it's a good point. Otherwise, if it is not there, it does not. Now, there are three clinical subtypes based on the age of onset. The infantile form is often fatal with few years, whereas juvenile adult forms, which present similarly, can have more protracted course. So this is from literature, the MRI picture, exactly same as our patient. See the picture, exactly the atrophy of the medulla. And see the picture, our patient, this patient. See the cervical cord here. Hyperdensitation in the cord and the medulla. Pons is preserved. That is the tadpole sign. Our patient also, if you look at that MRI picture, exactly like that. See this one. This is a pons, this is a tadpole. Okay. Any questions?
Sir, focal seizures can it occur, sir?
Yeah. Focal seizures indicate only that particular part of the brain is irritated. So that does not give a clue to the diagnosis. Only that part is affected more. The leukodystrophy does not mean me be exactly symmetrical. It can be affected one side more affected than the other.
Yes, sir.
For example, if you look at the brainstem also, it's not symmetrical. The affection is asymmetrical.
Yes, sir.
Okay. Any questions? Okay. Shall we close?
Thank you, sir.
Okay.
Thank you, sir.
Thank you.
sir.
Good night. Good night.
Thank you,
Good
sir.
night.
Thank you, sir.
Okay,
Night, sir.
Good night. Good night, all of you. Good night. We'll meet next week. We'll meet.